The actual change that affected my practice is the availability of both drugs in my practice. So when we start a new TKI for a patient with EGFR mutation, we basically tell them that there's two choices and explain them the toxicity profile, the outcomes that are going to be expected, and make a decision from there.
I think oncologists who treat this disease should carefully consider the results of Lux-Lung 7. It is possible that for younger and fitter patients that afatinib may be a superior alternative, whereas for older and frailer patients, standard gefitinib might be a preferred alternative. Those who wish to treat their disease more aggressively might enjoy superior efficacy as a result of afatinib. Those who value quality of life and very low toxicity might gain more benefit from single-agent gefitinib.
The recent results of Lux-Lung 7, where the overall survival data were presented, suggested that there was no significant difference between overall survival outcomes between afatinib and its comparator arm gefitinib. This will not necessarily change my practice. Again, as I have mentioned already, the important selection criteria for me will be based on an individualized basis with the patient in front of me regarding response rates that I'm trying to achieve, the progression-free survival I'm trying to achieve, the toxicity profile that I'm trying to achieve, and it will require an individualized discussion. I don't think that this is necessarily going to change the way that I impart my practice on a day-to-day basis. Whether it will impact another physician will be something that they will need to discuss again with the patient in front of them. What this does still allow us to do is to recognize that we have options. There are more than one option, just as there are more than one options in many of the spheres that we do.
We are so used to wanting clinically confirmed overall survival that for some people this might be a disappointing result. But for me, in terms of the day-to-day management of end-stage lung cancers, I don't think it makes that much of an impact. I'm still going to try, if they have the required mutations, it will be on the top of my line of medications.
If the question is if this does the overall survival data presented here change what we're going to do? No, not at all. I think we've already seen the data. I think that it will just solidify that what we're doing is probably right.